Hello. I guess we can start. Probably. Good afternoon, and thank you for being here for the presentation. I'm Sindhoora Mavuram from the medicine department, and today I'm here to talk about exactly predicting the perioperative risk. And I would be focusing on the 2014 guidelines, the recent ones released by the ACC-AHA jointly, the task force, which was released sometime in August of last year. But I would be, focusing, I would be touching brief things about the other perioperative management what I found is essential, like the different medications and the role of PFTs, routine blood work and stuff like that, right? So we'll start on. So the purpose of perioperative clearance, or basically risk stratification, is not to get clearance, but it is to evaluate the patient's medical status and risk of complications along with the surgical procedure and the type of anesthesia. So, even recently, while I was doing my residency, it was commonly called as medical clearance. I've seen surgeons writing get medical clearance, but it's not such. You can never clear a patient medically for any procedure. You should expect some complications, or the patient inherently is at risk for some things. So the goal is to identify any unrecognized comorbid conditions and risk factors for medical complications of the surgery. And what you're doing essentially is to assess their severity and their stability, both preoperatively. And to establish a clinical risk profile for informed and shared decision making prior to the surgery. And our main role comes in here in recommending any changes that are needed in the management regarding any further testing, or do you need any further specialty consultations. So before we get into the details of all, I'll just refresher on the level of evidence and the strength of recommendations. So the level A, B, C, level A recommendation is data derived from multiple RCTs or meta-analysis and multiple populations evaluated. That means we have a pretty good amount of information. Level B is the data derived from a single RCT or non-randomized studies where only limited populations are evaluated. And 11C are essentially very limited studies. They're essentially cohort studies, case reports and all, right? And coming to the recommendations, the strength of recommendations, like class 1, class 2A, 2B, and class 3. So class 1, where the benefit outweighs more the risk, so where the procedure or the treatment, it should be performed, right? And class 2A is so there is substantial benefit. So you can there's still a need for further studies that can be done for these focused objectives. So you can say that it is reasonable to perform certain procedure or administer the treatment. So class 2B, where you can say is it may be considered. So there's on par the benefit and risk. It's it's very case based. Class 3 is essentially risk more than benefit. So this is essentially one thing we should not be doing at all. Right. So here we are. The whole perioperative team includes us, as the medicine team, the anesthesia, the surgeons, and with the patient's best interest at heart. So the perioperative risk procedure is a combination of both the procedure risk and the patient's risk. The procedure risk, again, involves both the surgical risk, the type of surgery, and the type of anesthesia. So let's get into the recent guidelines that published in the Journal of American College of Cardiology. They released sometime in August of 2014 last year by the ACC and AHA task force. So they're essentially guideline on perioperative cardiovascular evaluation and management of patients undergoing non-cardiac surgery. So here, they essentially, most of the things are the same from the 2007 guidelines that we were using before, but there are a few things that I'll try to point out as we are going further. But they lay more emphasis on the importance of communication among the perioperative team, and they should include the patient in the loop of communication. And definitely, as always, appropriateness of care and cost containment. So you should order a test only if you think the result may change the patient's management, either surgical-wise or with the patient's condition-wise. So here, they start out with the defining the urgency of the surgery. So they define based upon time duration, like emergent surgery, which is needed like within the next 6 hours. Urgent within the 6 to 24, time sensitive can delay up to 1 to 6 weeks, and elective can delay up to 1 year. So I'll be doing simultaneous reviewing comparison with the 2007 and the 2014 guidelines. I didn't put it up there because it's redundant now because we won't be using it anymore. So the 2007 guidelines essentially don't provide any definitions regarding the timelines of the surgeries. They essentially divide only 3 kinds of surgeries based on emergency, semi-elective, and elective surgeries, but they don't give any time frame. The risk of the surgery. So here where is a whole lot of change has happened, I would think, to begin with. So it is based on both the surgical and the patient characteristics. They have only 2 kinds of surgical risk procedures, low risk and elevated risk. So the low risk surgeries are which have less than 1% of risk for any major adverse cardiac events. That could be an MI, non-fatal MI, non-fatal cardiac arrest, or sudden cardiac deaths. Right? And elevated risk surgeries are which include more than 1% of that surgical risk. So what all come under low surgical risk procedures are endoscopic procedures, superficial procedures, cataract surgeries, breast surgeries, ambulatory surgeries, essentially almost all of your day surgeries, right? Ambulatory day surgeries. So elevated risk procedures are vascular surgeries, intraperitoneal and intrathoracic surgeries, head and neck, orthopedic, and prostate surgeries. So they did not clearly identify as to the different kinds of laparoscopic procedures that are essentially intraperitoneal, but they didn't specify as to do the laparoscopic procedures do fall under elevated risk or low risk procedures, because most of those laparoscopic procedures are still ambulatory daycare surgeries, right? The 2007 one again has as all of you are aware, low risk, intermediate risk, and high risk surgeries. Okay, so the risk to establish any risk, it started out with calculating the risk for any major adverse cardiac events. So the prior guidelines have individually did the medical risk and the surgical risk were separate, but here in the current ones we have both combined and the medical and the surgical risk. So they include the RCRA, which is our from the medicine side, the revised cardiac risk index. And NSQIP is the National Surgical Quality Improvement Project. So that essentially is a 21-point questionnaire, which is basically done online, or it's web-based. It's more comprehensive, but it needs to be validated externally outside of those ACS. So the revised cardiac risk index, we do the scoring based on 6 risk factors: the high-risk surgeries, which you already dealt with in the earlier slide. Ischemic heart disease, heart failure, stroke or TIA, diabetes requiring insulin treatment, and renal insufficiency. I think there's a new RCRA thing coming up, I forget the name, which actually talks about not based on the serum creatinine, but based upon the GFR, less than 30. So that still need to be worked upon. So this is how the risk based upon the number of predictors, how the RCRA scoring comes up. This is how you estimate the risk of cardiac death or the non-fatal MI or cardiac arrest. So 0 or none is 0.4% risk, 1, 0.9%, 2, 6.6. I'm sorry, it should be more than 2. Is almost more than 11% risk. So this was other surgical risk calculator I was talking about earlier. It's an estimate of the procedure-specific risk, which also includes anesthesia risk based upon the current procedure terminology code. Includes 21 patient-specific variables. So basically, it's a very comprehensive one, but it's very detail-oriented and needs external validation. So it does also talk about cardiac biomarkers, not essentially your troponins, but usually your BNP and pro-BNP, which could be an independent predictor of cardiac risk, but they should be done in the right situation. Further recommendations have not been well given out in this guidelines as well. So these are the different active cardiac conditions, your cardiac risk factors, clinical risk factors that we talk about. Is unstable coronary syndromes, less than 30 days, decompensated heart failure, significant arrhythmia, severe valvular diseases. So, compared to the 2007 and the 2014 guidelines, I know the basic algorithm have changed how to further progress with the further testing and all, but pretty much about these things, they have remained the same. I mean, if anyone has significant valvular abnormalities or arrhythmias, they suggest that they still go ahead and do further testing prior to providing any risk stratification for the procedure. Saying that, they do mention out specifically something, few differences have shown up in the valvular heart disease section, with the mention aortic and mitral stenosis are at a greater risk than any regurgent valvular lesions, meaning regurgent valvular lesions are well tolerated. So they do suggest again that echocardiography is recommended in patients suspecting of having moderate to severe of these valvular lesions if it has not been done in the last year, or there has been a change in the significant change in the patient's clinical condition since his last date of evaluation. So, if in case of asymptomatic severe aortic or mitral regurgitation or aortic stenosis patient, they do recommend that even if a surgery is high risk, it may be reasonable to proceed with the surgery by using appropriate, preoperative, intraoperative hemodynamic monitoring. Would be like an A-line, central line, and possibly a catheter, pulmonary arterial catheter. So it's still go ahead, in case of asymptomatic severe valvular lesions, it's still okay to go ahead for the procedure, provided you have facility to do all this intraoperative monitoring. So we come again to the patient functional capacity. How do you do it? By estimating your metabolic equivalence, right? So up to 4 meds, there's essentially your ADLs like less than 4, like you can walk a block, do a light work, or those are all like 1 to 4. And then 4, climb a flight of stairs, walk on level ground, run a short distance. When you come up to the 7 and higher, like excellent metabolic equivalence, you talk about participating in competitive sports, swimming, doing bowling, dancing. So this is essential in this carries importance when you're trying to do your risk stratification again, which would come up in the next slide. So this is a whole the algorithm for the proposed risk stratification. So patients scheduled for surgery with a known or risk factor for CAD. So the risk factors we've already talked about, right? So if there's an emergency procedure, yes, you should obviously go for the surgery. If it's not an emergency procedure, you should evaluate the patient if the patient is having any acute coronary syndrome, meaning your unstable angina, NSTEMI, or STEMI. So if yes, you should actually evaluate the patient, and then you should proceed along the guideline-directed medical treatment, how you should proceed for those specific situations. So if patient is not having any of those ACS currently, so then you should estimate his perioperative risk based upon the surgery, specifically the low-risk procedure, less than 1%. Then you should obviously, low-risk procedures, it obviously doesn't need any further testing. So you can go ahead proceed with the surgery. For elevated risk surgeries, then you should establish your metabolic equivalence, moderate or greater than 4 meds functional capacity. So if it's excellent, it's like 10 and more metabolic equivalence, again, you don't need any further testing, you can proceed for surgery. You have 4 to 10, still, there's no need for any testing, you can proceed for surgery. If the patient doesn't meet equal to 4 or 4 to 10 meds, then poor or unknown functional capacity, less than 4 metabolic equivalence, or when the further testing will impact the decision making or perioperative care. If your answer comes out to be yes, then you should proceed with the pharmacological stress testing. If not, then you should proceed to the surgery according to your GDMT. So pharmacological stress testing, if it's normal, then obviously proceed to surgery. If it doesn't, then you should go ahead with coronary revascularization, meaning you're doing your cath and stuff. So whole of this thing has changed because initially the previous guidelines were talking more about the clinical risk factors, more concentrating on the clinical risk factors more than this metabolic equivalence. Okay, so this is a little dizzy slide. It talks about the preoperative need for EKGs, your assessment of LV function, meaning your echocardiograms, and exercise stress testing for MIs, your cardiopulmonary exercise testing, or non-invasive pharmacological testing, meaning your stress echoes, and preoperative coronary angiogram. So we'll break it up, right? So the EKG, so routine pre-op EKG for asymptomatic patients in low-risk procedures are a definite no. It's a class 3 recommendation. You don't have to do that. And preoperative resting, and if you notice, none of them is a class 1 recommendation, any of them. So everything, all these prior testings are like case-by-case basis. You have to pick and choose, right? It's reasonable, or maybe you can do that. So preoperative resting 12-lead EKG for patients with a known coronary heart disease and other significant structural heart disease who are going for high-risk surgeries. So it's still okay. You can do them. Similarly, asymptomatic patients, except for low-risk procedures. So assessment of LV function, again the same. Routine assessment, routine pre-op evaluation of LV dysfunction is not recommended. Like, patients have been chronic hypertensive for years and years and years. Do you have to do an echo prior to the surgery? No. It's all based on the symptoms, right? So when do you do that? It's reasonable, preoperative evaluation for dyspnea of unknown origin. Yes, you might want to do that. Or worsening dyspnea, in a patient, established case of CHF, but with worsening dyspnea, not evaluated in the recent past time. And then reassessment of LV dysfunction in clinically stable patients, it may be considered. It's a 2B, it's not 2A, it's 2B recommendation. Meaning already a CHF patient who are stable compensated CHF patients. Then exercise stress testing for myocardial ischemia and functional capacity. Routine screening, again a no. Class 2A, for patients with elevated risk and excellent functional capacity, we can still go with exercise stress testing. Then elevated risk and unknown functional capacity, it may be reasonable to perform exercise stress testing if it will change management. So remember, again, the stress is on any test only if it will bring about a change, or it can bring upon a change in the patient's management. Right? Then exercise test testing, also the same as a 2B recommendation. And your stress echo as well. So routine is again a no. So it's reasonable in patients at elevated risk for non-cardiac surgery with poor functional capacity to undergo dobutamine stress echocardiogram or myocardial perfusion imaging if it will change management. So if it's always, this is where probably more work or more stress has to be given upon, or more studies have to be done in this aspect, because it leaves us in a gray zone. And I feel that maybe we end up doing more of these tests just because it is reasonable or it may be done. It does not definitely say no. It does say definitely no in only few of these conditions. Then coronary angiogram, definitely not a routine preoperative procedure. So then they do talk about certain medications in these guidelines. So perioperative beta blocker therapy, a class 1 recommendation to continue them who have been on it chronically. Then class 2A, to guide them by clinical circumstances. So in patients with intermediate to high risk preoperative test, it may be reasonable to begin beta blockers. And then with more than or equal to 3 RCRA risk factors, it may be reasonable to begin beta blocker therapy. It's a 2B recommendation. So when do you start it? The timing has been specified. So it should not be started on the day of the surgery. It should be started at least more than a day before the surgery. Then perioperative statin therapy. So statins should be continued in patients currently taking statins. It's a class 1 recommendation. Class 2A recommendations, statin use is reasonable in patients undergoing vascular procedures. And class 2B recommendation, you can consider starting the patients on statins with your RCRA, who has RCRA risk factors and is going for an elevated risk procedures. Other medications, continuing on, they do talk about alpha-2 agonists. There's no benefit, so they are not usually recommended. So class 2A recommendation regarding your ACE inhibitors or ARBs, continuation is reasonable, but if they were held for some reason, it should be resumed as soon as possible. So So here is one other change from the previous guidelines, including when to proceed for a surgery after PCI, a recent PCI. With so patient with coronary stent, the stent implantation, if it was done less than 4 to 6 weeks, so if it is an elective surgery, yes, you should delay the surgery at least 365 days, 1 year in a case of a drug-eluting stent, or 30 days in case of a BMS. But if it's not an elective surgery, so you can just continue your dual antiplatelet therapy unless the risk of bleeding is greater than the risk of thrombosis. That's class 1 recommendation. But if the stent was placed more than 4 to 6 weeks, meaning more than 1 to 2 months. So if it is a drug-eluting stent, more than 30 days, but less than 1 year, you should obviously check for risk of surgical delay is greater than risk of DES thrombosis. So if the risk by delaying the surgery is more, then obviously you can proceed with the surgery after 6 months. So the prior guidelines were recommending to actually wait for a whole 1 year. So this is new in the 2014 ones. So if you think the surgery cannot be delayed for more than 6 months, please go ahead and proceed with the surgery if the DES was placed after 6 months. So, but if the surgical delay, the risk is not that high, then you can just delay the surgery until 1 year in case of DES and 1 month in case of BMS. Okay, so then you should the surgery demand discontinuation of those plavics. If there's no, then continue your treatment, and if it states that if it does require that the plavics needs to be discontinued, then you can just continue on aspirin. Don't discontinue aspirin, but just continue on aspirin and then resume your plavics as soon as possible. Right. So once you've established when to to proceed with the surgery or not, now when to stop the antiplatelet therapy. So aspirin can be discontinued, can be stopped 3 to 7 days prior. Your Plavix and Brilinta 5 days before, and Prasugrel 7 days before the procedure. So those are all mentioned in those guidelines. They don't essentially talk about, from now on I'm going to talk about the most frequent things that we encounter while doing your pre-op risk stratifications, both as an inpatient as an outpatient. I think it's one of the most common consults that you encounter upon. 1/3 of your consults are pre-op consults. So this is about your anticoagulation, right? So first we should establish a pre-procedure thrombotic risk, meaning is the patient a low risk or a high risk for forming any clots perioperatively. So low risk conditions would be bileaflet aortic valve without AFib or other risk for stroke. That's heart valves, and in AFib, CHAD score of 0 to 2 with no previous strokes, and VTE, I'm sorry, that should be more than 3 months with no other risk factors. That's a typo there. It should be a venous thromboembolism more than 3 months with no other risk factors. So all these conditions, they do fall under a low risk for perithrombotic complications. So who all come under high risk for a peri-procedure clot risk? So in case of thromboembolism, any recent venous thromboembolism less than 3 months with associated hypercoagulable conditions, severe thrombophilias, and in AFib with recent stroke less than 3 months, and in artificial valves is mechanical mitral valve, definitely high risk, definitely at high risk. Cage ball or tilting disc prosthesis is a type of the process put in, or any recent stroke with having any mechanical heart valve less than 3 months. So these are patients with high risk for clot formation. So this is taken out from Up to Date. It talks about the bridging essentially with Coumadin. Do you bridge, not to bridge, when to bridge, how to bridge. So either surgery elective or emergent, urgent. If it's elective, then you should see is warfarin interruption needed for the surgery. If no, bleeding risk associated with the surgery is low, then you don't have to stop the warfarin. But if the bleeding risk associated is high, then obviously you should hold the Coumadin, but you should think about, is bridging needed in the meantime? So is bridging anticoagulation needed? No. When? In those patients who are at a low risk for thromboembolism, meaning all these patients, right? So they don't need any bridging. So in those patients, what do you do? So 5 days before the procedures, you stop your warfarin, your Coumadin. Then day before, you check your INR. INR should be typically less than 1.6. Based upon the surgery, preference, you can either give vitamin K at that time. When to start resume warfarin? It can be done, as soon as the patient can tolerate the oral feeds. You can start up warfarin on the day of the surgery too. Okay. Is bridging anticoagulation needed if it's an yes, who all? That would be all your high-risk patients. So you would stop your Coumadin 5 days prior to the procedure. Then after 2 days, you can start your bridging. Either it would be your Lovenox or your heparin, unfractionated heparin. Then prior to the procedure, day before the procedure, check your INR again. Check to see if it's, if it should be, ideally should be less than 1.6 for the procedure. When to resume it? So after attaining good hemostasis, your bridging can be resumed 12 to 24 hours post procedure. Okay, so these are, nowadays you would see patients on all these other novel anticoagulants, when to start, when to stop, right? So Coumadin, 5 days. Dabigatran, based upon creatinine clearance, you can, if the creatinine clearance is more than 50, you can do 2 to 3 days prior to the procedure. If less than 50, 4 days, and if it's actually less than 30, you should stop it 5 days prior to the procedure. Then heparin 4 to 5 hours before, last dose of Lovenox should be 24 hours prior to the procedure. Xarelto, almost like rivaroxaban, it follows the same lines, 2 to 3 days and 4 days prior to the procedure. And in creatinine clearance less than 30, Xarelto is not recommended. Right. So another common thing is your steroids. Okay. So how do you assess the need for stress-steroids pre and perioperatively? So when do you suspect suppressed access? If you see a patient on doses more than 20 milligram per day of prednisone for more than 3 weeks, or its equivalent like 16 milligrams of methylpred, 2 milligram per day of Dexa, 18 milligram per day of hydrocortisone. So these are the patients whom definitely needs perioperative stress-steroids. And if you see a patient on glucocorticoids with you think clinical Cushingoid syndromes, then definitely it's worthwhile either to proceed with further testing to establish deficiency status, or you can just presumably give stress-steroids. Patients who are taking like less than 5 milligram prednisone or its equivalent, they do not need any perioperative steroids, right? And patients who take some doses in between like 5 to 20 for unknown duration of time, then it's worthwhile either to proceed for further testing to establish any deficiency states, or just go ahead and continue with your stress-steroids. So what are the recommendations? So for minor procedures, like surgery and local anesthesia, you can take the morning dose. Those who are already on steroids, right? For moderate surgical stress, examples like lower extremity revascularization, total joint replacement, they take the doses. Then prior to the procedure, they get 50 milligrams of IV hydrocortisone, and then 25 milligrams every 8 hours for the first 24 hours. Then they resume their usual doses. For major surgical stress, like in esophagogastrectomy, total proctocolectomy, open heart surgeries, they take their regular dose. Then the dose, instead of 50, they get 100 prior to the anesthesia. Then 50 milligrams every 8 hours. Then taper dose by half to until they get to their maintenance level at what their usual dose is. So these are so other medications. So digoxin, yes, can be continued perioperatively. So we talked about statins earlier. Now we talk about the non-statins, like your fibric acid and then ZT and stuff. It's recommended to be held perioperatively just because of their high incidence of rhabdomyolysis, myalgias and stuff. And diuretics, there's not a clear-cut recommendation as to to be stopped or not, but usually it is recommended to stop the day on on the morning of the surgery and to just resume as soon as the patient is taking oral fluids. H2 blockers, PPIs, can be continued in the perioperative period. Inhaled beta agonist, to be continued. Theophylline. I mean, some places do say it's discontinued, but the CMDT from the 2015 CMDT, it does say that it can be continued, and actually it should be continued, they say. But you should establish their level prior to the procedure. You should check their level prior to the procedure. Make sure they're not in the toxic range. It causes it has the potential to cause serious arrhythmias and neurotoxicity. Sorry. So, and then hormone therapy with the risk for VTE. So who are undergoing for high risk surgeries, they're recommended to just stop 4 to 6 weeks prior to the surgery, just because of their elevated risk for VTE. Gout medications can be held on the morning of the surgery, and your BPH, medications for your BPH, like your alpha-1 antagonist, cases have been attributed with the use of them with intraoperative floppy iris syndrome, which is an intractable intraoperative iris prolapse with which you see with cataract surgery. Right. Previously they used to say they stop it, but nowadays, none of the eye surgeons are not recommending or requesting for it, because usually the half-life of these medications are typically long. They stay for weeks to months. So there's no benefit in stopping them. Then your rheumatological agents, methotrexate, to be continued in the perioperative period with normal renal function. But in case of renal impairment or bone marrow suppression, active infection, they should be held 2 weeks preoperatively. Sulfasalazine, azathioprine, held for a week prior to the surgery. Hydroxychloroquine has few limited side effects, so they can be taken. TNF alpha inhibitors should be stopped at least 2 weeks prior to the surgery and can be resumed once the wound is fully healed. And mention has been made about leflunomide. Not enough data is present, either to recommend to stop or continue it for leflunomide. So, very commonly seen in almost all of our patients here, psychotropic agents. TCAs, tricyclic antidepressants, can be continued. SSRIs to be continued. Okay, so your monoamine oxidase inhibitors to be held because of their significant interactions with most of your anesthetic agents. And lithium valproate to be continued. Antipsychotics used with caution because of their risk of QT prolongation and their additive risk of sedation and hypotension along with their anesthetic agents. And your anti-anxiety medications, like patient who's on chronic benzos, buspirone, to be continued. And patients who are chronic opiates, they suggest to continue based upon your anesthetic risk, obviously. If the patient is going for general anesthesia, then to be used with caution. All right? Okay. So at least one out of 10 patients I've seen here at least are on one or other of these herbal medications. So it's definitely worthwhile to look into what could be the effects of the herbal medications. So always make sure to check with the patient all their medications, review their medications, including any over-the-counter or herbal medications. So this is a list of 8 most commonly used herbal medications. Ephedra, it may increase the risk of heart attack and stroke, so should be continued at least a day prior to the surgery. Garlic, we use it on an everyday basis. So increased bleeding risk, at least 7 days prior to surgery. Ginkgo, bleeding risk, at least 36 hours. Ginseng may increase the bleeding risk and hypoglycemia, so at least 7 days. Kava has an increased sedative effect along with your anesthetics, so at least a day prior to the surgery. And an association has been made with fetal hepatotoxicity, like, post-operatively. St. John's wort, major interaction with other medications, so at least 5 days prior to surgery. Valerian, I'm not sure ever like, come across this one. Have any of you? No. It's like, looks like to be, a long half-life, have to be like tapered weeks before surgery. Echinacea, allergic reaction and immune stimulation, but there's not enough data to suggest any, preoperative management. Okay, so last but not the least, we tend to miss out on all, when you look at the picture, I see most commonly in the clinic, we tend to focus on your RCRA risk stratifications. Okay, you go ahead, do the stress test. If don't need it, you can go for the surgery. But we tend to forget that patient has to be risk stratified as a whole, meaning his liver function, his liver function, and his lung. Everything has to be taken into account, his lung functions, right? So clinical risk factors for pulmonary complications. Type of surgeries, upper abdominal cardiothoracic surgeries, and prolonged anesthesia time more than 4 hours. Age more than 60, COPD, CHF, severe debilitating systemic diseases, tobacco use more than 20 pack years, low serum albumin, of course your OSA, functional dependency or prior stroke, and impaired cognition sensorium. All these are at a significant risk of post-op pulmonary complications, post-op pneumonias, and hypoxias requiring mechanical ventilation. So, and what's the role of PFTs here? So it is a subject of constant debate. PFTs, routine pre-op testing is always debated. So how does it help us? So it helps us to identify and characterize pulmonary diseases with unexplained symptoms prior to any major surgeries. In case of known lung diseases, your clinical assessment is by far the best. PFTs don't add no more information on top of that. And even in order to do PFTs, what's our cutoff? There is no cutoff as to at what PFTs do you not to do surgery for non-lung resection surgeries, right? So I would say we can consider PFTs only if you're unsure of their underlying pulmonary disease prior to surgery, prior to any major risk procedure, right? Your chest X-rays, not a routine procedure, but it may be considered for persons undergoing major procedures with age more than 40 or known cardiovascular risk. ABG is not indicated as a routine, right? Similarly, your routine blood work not indicated as a routine unless patient is known to have significant liver or renal impairment, or known to have a bleeding tendencies or a family history of bleeding tendencies, right? So what are the recommendations for to avoid those post-op pulmonary complications? To optimize your preoperative status in case of preoperative pulmonary status in case of COPD and asthma, meaning continuing your inhalers and steroids and their regular maintenance medications. And also incentive spirometry, 15 minutes every 2 hours, and your deep breathing exercises every hourly. They should be started preoperatively and continued 1 to 2 days post-operatively, have a significant impact on reducing your post-op pulmonary complications. So any patients you see with COPD, asthma, or chronic bronchitis emphysema, so this always, it is always recommended to be in your recommendations, and especially also in patients who have OSA, OHS, like you think are morbidly obese patients. And your CPAP and intermittent positive pressure breathing. So smoking cessation, retrospective studies have pointed out, have shown us that smoking cessation at least 1 to 2 months prior to the surgery has shown to improve your, shown to reduce your post-op complications. Specifically, if at least 4 weeks prior to the surgery, then it has shown pulmonary, reduced pulmonary complications and also surgical wound complications. So that's something worthwhile to discuss with your patients. Okay. So still with all these recommendations, I'm sure most of you have many questions. That was what I was after reading all through the guidelines, because it still keeps us in a gray zone as to what to do, right? It does tell about certain recommendations, but it doesn't talk about, it doesn't stress about significantly on the other risk factors, clinical risk factors other than your ACS. I know for ACS we have a set out thing, but your other risk factors, meaning your valvular conditions and everything, it doesn't clearly give out any recommendations. Right, so I think we still might end up doing more of these stress testing prior to stratifying a patient. Okay. I'm ready to take any questions you have. And a little bit too exhaustive, and you should note that I didn't include still the management of diabetes, thyroidism and everything, because they're all topics in itself. So, anything? Hope it was helpful. Thank you.